David Molyneux from the Liverpool School of Tropical Medicine, Paul Tsaku of the Leprosy Mission of Nigeria, and Zila Zaize of Redress Liberia, who will be talking about disease management, disability, and inclusion, and why people-centered approaches are central to beating NTDs. As a reminder, these three presentations will run consecutively, and then we will ask the questions at the end. So just keep adding your questions to the chat, and we'll discuss them at the end of the third presentation. Thanks so much.
Good afternoon. My name is David Molyneux. I'm working with Freddie Bailey, and we're presenting on the theoretical underpinning and implications for advocacy and practice in relation to mental health and NTDs. And this is a rapid fire lecture, and I shall be very speedy. The first point I'd like to make is that we know that mental illness has the highest burden of disease globally of any condition, and recent studies have suggested that the actual burden is at least 30% higher than has been published by the global burden of disease. So mental illness and its associated conditions is first in terms of the disease burden, and particularly in terms of years of life lived with disability. And the key points here are from a World Bank publication. Mental health is one of the most neglected areas of health. Investment in mental health yields a significant return on that investment, and a multi-sectoral approach, an integrated approach, is required. And the psychosocial needs of vulnerable groups, which this group of the NNN is committed to significantly improve, is key to this. Of course, the published figures in the slide earlier were pre-COVID, and a recent meta-analysis and systematic review has shown clearly that the prevalence of depression, anxiety, and other conditions associated with mental health has significantly increased during this period. So, as we know from the UK and other countries, the social consequences and mental health problems of COVID are significant. We got involved some years back in looking at mental health of neglected tropical diseases, and the diseases on the left of this slide are ones which we know have significant impact on the mental health of those people afflicted by these conditions. And this slide summarizes the issues around disablement, disability, stigma, deformity, and blindness. And each of these ovals has implications for the mental health of those afflicted, but I would like to also emphasize that many of the afflicted with neglected diseases depend on carers, and that has consequences as well. So we have both economic, social, and mental health consequences of neglected tropical diseases. We involved ourselves some years ago in assessing the burden of mental health in lymphatic filariasis, using some of the figures that have been produced in terms of the prevalence of depressive illness in those infected with filariasis and showing symptoms. And these ranged from nearly 100% in cases in Kerala, and a more recent study in Nigeria, where many people, 42% had mild, 31% moderate, and 26% had severe depressive illness. And the duration of that illness was 17 years, hence the really important issue of years of life lived with a disability were important. And our conclusion in the 2015 paper was that the daily burden of mental health alone for filariasis was at least twice and possibly more of that attributed by the global burden of disease to filariasis in its study in 2010. And the important thing here in measuring the depressive illness in neglected tropical diseases is to look at the disability weights which drive the burden of disease. And depressive illness, when you are severely afflicted by depression, has a disability weight of 0.655. But the disability weights for some of these NTDs are very low indeed. Filariasis was only 0.1. Cutaneous leishmaniasis, which we studied, was less than 0.1. And so we have here a situation where if you are depressed or showing depressive illness from NTDs, you should be looking at a disability weight for your condition far exceeding that of the attribution that the global burden of disease gives to neglected tropical diseases. And there's a missing burden here, and this is a statement from de Vlas's study on the burden of NTDs. But the conclusion here is that that burden, which they looked at, didn't take into account mental health, discrimination, and disfigurement. And leprosy and filariasis were examples they used. So the burden of mental health associated with neglected tropical diseases does not appear to be included by the mental health community in the calculations of depressive disorders and anxiety. And nor are the roles that caregivers play and the impact of on the caregivers of caring for somebody with a mental health condition associated with neglected tropical diseases. So that needs to be factored into the burden, as we did for filariasis. And this is an example study of depression in caregivers in blind patients in India, where the prevalence of depression was 48% in the cohort, which were looking after people who were severely visually impaired. And this has implications because caregivers clearly cannot execute their lives in a normal way if they have that responsibility. In the case of African trypanosomiasis, although the numbers of patients now afflicted by this condition are reducing, one of our studies in DRC, recently published in the Transactions, showed that, surprisingly, people who have been treated, particularly children who had acquired congenital sleeping sickness, have permanent and irreversible neurological sequelae, despite the fact they've been treated. And some of these patients in the study we looked at were infected over 20 years ago. So it just demonstrates the burden, not only on the patient, but on the caregiver of somebody who has permanent neurological sequelae associated with sleeping sickness. So the key messages are that mental health globally is the major health burden, particularly in terms of the years of life lived with disability. That the mental health burden was underestimated even before COVID, and we know that COVID will have a major impact. But COVID is an exemplar of the comorbidity of mental health associated with an infection, just like the NTDs are. The comorbidity of mental health and NTDs is now on the radar screen, but the contribution to the NTD burden in terms of mental health really is yet to be adequately quantified. And just to emphasize that the disability weights of mental health estimates are critical in validating the true NTD burden. And finally, many patients with NTDs require this permanent support from caregivers, which has downstream economic consequences for the family and community. And the examples I give are filariasis, podoconiosis, sleeping sickness, Buruli ulcer, onco, snakebite, trachoma, and neurocysticercosis. And that is a very significant number of people not only suffering from the affliction itself, but also the mental health consequences of that condition. Thank you for listening, and I wish you a very good deliberation in this rapid fire session. Thank you.
Hello and welcome to this presentation on example of inclusion from Nigeria based on the Neglected Minds Kindling project. The title of this project is the Neglected Minds Kindling, Promoting Mental Health and Well-Being of People Affected by Skin NTDs, a formative piloting of WHO Guide on Mental Health and NTDs Integration. The site for the study is Konshisha and Boko local government areas of Benue State, central Nigeria. This is site where partners in this project, specifically TLM Nigeria and CBM, have been carrying out activity with people affected by leprosy and lymphatic filariasis. So here in this presentation, I'll be pointing out areas where there was active participation of persons affected by NTDs. And first, we have the community engagement and focus group discussion, where we have group discussion with persons affected by leprosy and lymphatic filariasis. We did that pre-intervention and post-intervention. And in this focus group discussion, the participants were able to voice out their expressed priorities based on their health, need, and well-being. So an analysis of the expressed priority of the participants, majorly you will see that with regards to their health need, treatment is the key area. And with regards to their social needs, money is the key area. So you will find out that their priorities is that we need money to solve this problem or that problem, and then health, they need treatment to be able to achieve good living. So the next item in our study where inclusion can also be identified is the theory of change process, which is an iterative theory-driven approach to delivering an intervention. So here we invited participants, including persons with leprosy and lymphatic filariasis. And during this process, the participants were able to outline the activities that are required in order to achieve a certain target for people affected by NTDs. Here you have the theory of change map, which is the outcome of the theory of change process, and the ultimate impact from the theory of change map, as you can see here, is that people with NTDs have improved well-being, community inclusion, and are able to achieve their aspiration. And there are several steps that have been outlined in order to achieve that impact. And in that, you will find key activities, including user group facilitation, community engagement, training, system strengthening, and policy framework. There are several other activities here in the theory of change map, which, if they follow, the ultimate impact will be achieved. So the take-home point is that the people affected by NTD should be given a voice. They should have the opportunity to express themselves, especially with regards to intervention that concerns them. This will give them a sense of belonging, and it will lead to improved self-esteem. So, thank you very much for listening. I will also want to appreciate the contributors to this. This project received financial support from the Coalition for Operational Research on Neglected Tropical Diseases, (CONTD), through the Task Force for Global Health, and it's funded by the UK aid from the British government. The partners in this project are the CBM, the University of Jos, and the Leprosy Mission Nigeria. Thank you.
Hello, everyone. I bring you greetings from Liberia. I am Zila Zeze, the Liberia Country Program Manager of Redress, a research collaboration of the Liberia Ministry of Health and 7 of its collaborating entities partners. I am glad to be sharing with you examples of inclusions from our ongoing redress project. Liberia, although founded in 1847, is one of the world's poorest countries and has reportedly 12 entities. About 64% of its population lives below the poverty belt, and 86% are illiterate. Liberia suffered 14-year civil crisis, which still impacts access to basic social services, including healthcare. Women, faith, and traditional leaders were central to its peace process. Liberia consists of diverse ethnic groups, with indigenous groups more concentrated in rural communities. They are holding on to long-standing traditional and spiritual beliefs about the causes and management of illnesses, including NTDs. Disparity in social services are affecting rural dwellers. Since 2016, Liberia has been implementing a 5-year strategic plan to integrate the case management of NTDs into its health system. Several barriers to NTD services have been noted thus far, including limited capacity of health workforce to identify and diagnose diseases, limited medicines and medical supplies, lack of awareness in communities about these health conditions, and stigma experienced from community and health workers. Redress is a research platform that is utilizing a person-centered approach to evaluate existing health systems interventions for the management of severe stigmatizing skin diseases in Liberia. Our participatory action research approach brings on board community stakeholders as co- and peer researchers. We have recruited and trained several cadre of community stakeholders who are engaged in all phases of the research. Amongst them are people affected by NTDs, faith, and traditional healers. Community stakeholders, including women groups, people affected by NTDs, faith, and traditional healers, are engaged and involved in understanding, reflecting on, and documenting challenges and developing solutions together. They remain key actors throughout all phases of our participatory action research. Several strategies are being utilized to effectively engage and involve community stakeholders in identifying challenges and finding solutions to them. One of the strategies has been to enable and empower local stakeholders to conduct a photo voice research in which they serve as co- and peer researchers. Persons affected by entities and health workers facilitated trainings for traditional and faith healers, and the healers thereafter conducted photo voice studies. These basically illiterate and semi-literate stakeholders were trained in the use of mobile phones, an experience that was quite new to several of them. For a period of 2 weeks, faith and traditional healers took pictures in their respective communities relating to issues that were important to them. The individual peer researchers discussed the meaning of each photograph. They picked 10 to 20 key photos that represented key issues to them. They discussed these photos together, and through an exhibition, we worked together to develop solutions to the key issues. The faith and traditional healers described their involvement in an ongoing redress project as unprecedented. Many described their newly gained abilities to navigate mobile phones and do research as exceptional achievements. They described this study as a platform that is allowing their voices to be heard, and they see redress as a key action toward breaking the barriers that excluded faith and traditional healers from health planning and decision making. These pictures and narratives are excerpts from their findings. In the photo to the far left, a traditional healer explains that a client who had not received adequate treatment at the health facility resulted into seeking traditional medicine at his facility. In another photo, we see a pastor conducting a service. He explains that the church provides psychosocial and trauma healing classes for members of the community. He further added that not all conditions require medication or hospital-based treatment. In another photo, a lady who was attempting suicide was rescued by a pastor who provided her counseling, and currently she lives with the pastor. In the photo to the far right, a traditional healer accompanied a client to the hospital. He explained that the client reported to his traditional facility for treatment, but realizing that the condition didn't require traditional therapy, he resolved to accompany the client to the medical facility and ensuring that the client received medical attention. The faith and traditional healers presented solutions toward the delivery of severe stigmatizing skin diseases services, including providing collaboration between formal and informal health sectors, building capacities of informal providers to identify and refer NTD's cases, and establishing communication and engagement platforms between formal and informal providers. Their recommended interventions will inform the redress planning and intervention phases. We extend thanks and appreciation to our collaborating partners and funders. And finally, we say thank you all for listening. Thank you.
Thank you to David, Paul, and Zila for those presentations. What we'll do is for the next about 8 minutes or so, we're going to direct any of your questions to David, Paul, and Zila as they come up. And then if we've gotten through those and we have some extra time, we will bring back the other presenters and address any remaining questions. So please feel free to keep adding your questions for these 3 presenters or for any of the previous presenters as well, and we'll try to get to all of the questions. So I see we have Paul and Zila. Do we have David with us? We do. Perfect. Great. Thank you 3 for those presentations. And I'm going to start with you, David. We have a question for you from Luke Sen. He says, we know several countries where NTDs are endemic lack mental health professionals. Do you have any specific orientations or suggestions for NGO partners supporting the NTD elimination globally?
Hello, can you hear me okay?
Can hear you perfectly.
I think the first point to make is mental health professionals of all sorts are in short supply everywhere. They're in particularly short supply in endemic NTD countries, clearly. And I haven't got the figures in terms of 1 per 100,000 or 1 per million, but they're very low. I think practically for what we're seeking to do within the NTD community is for NTD implementers on the ground, and particularly NGOs, to start to work together with those groups and institutions, be it academia, be it in the health service, to work with those who are engaged in providing mental health support at whatever level, to engage and develop more collaborative activities, and basically communicate and advocate from the NTD side with the people who are responsible in country for mental health, be it at the ministry level on the one hand, or at the NGO level on the other, and the implementers. I think this is the only way forward because it's likely to be far more resource effective. So that would be my suggestion. I think my colleague Freddie Bailey, when he visited Ghana under the auspices of Sight Savers, did make some progress in that regard. And I think you could also look at specific conditions. I mean, in Ghana, we've been looking at Buruli to see how services for Buruli ulcer can be integrated with some kind of mental health provision and support to address the issues of depressive illness in particular.
Thank you, David. And I'm going to stay with you for just a follow-up question. So Luxen asked about what the NTD's NGOs can do. I'm going to flip that, and ask, you mentioned that the burden of mental health is not included in the calculations for these depressive disorders. So how can we engage with the global mental health community in recognizing that NTD burden?
We sought to do that. I mean, I think we have to make contact with the leaders in the global mental health community, and I have indeed been in communication with Vikram Patel. I think the problem is trying to persuade the global burden of disease people that mental health issues and burden is not included currently in their measurements of NTDs, and indeed it should be. But their response to that will almost certainly be, well, we've included it in our general estimate of mental health globally. I don't think that's the case. I've been through many of the papers that have been produced on global mental health from groups in King's London, Patel's group, Ferrari's group, and I can't see any reference to NTDs in any of those papers. And when I spoke with Vikram Patel directly, who's recognized as the global mental health leader, he wasn't aware of the linkage between depressive illness, anxiety, and so on created by NTDs at all. I think that we just have to try and tap into that community. What we need, in my view, is a significant research activity involving a coordinated group of actors to work on moving forward the calculations that we started, because we've only scratched the surface. I mean, I didn't have time to mention, for example, snakebite. Big programs on snakebite supported by the Wellcome Trust. We need to get an £80 million committed to snakebite research by the Wellcome Trust over the next few years. We need to actually try and plug into that, because if you look at the numbers of snakebite cases a year, we're looking at deaths. I mean, in snakebite is about between 80 and 100,000 a year deaths, but disability is of the order of 3 or 4 times that, 400,000 people, many of whom will have permanent disability as a result of snakebite. That has a huge impact on communities across the globe. I mean, particularly in Sahelian areas of Africa and India. We have no measure of the burden of mental illness in those people, but they live a long time with permanent disability, and in many cases have suffered amputation, serious surgery as a result of the need for skin grafts, and so on. And the same applies to cutaneous leishmaniasis, and we've studied that as well. And the estimates of the burden in leishmaniasis, cutaneous leishmaniasis, as compared with the global burden of disease study, is probably of the order of 30 to 40 times that which is published by the GBD. We need a concerted effort to try and get to the bottom of what the true burden of disability associated with NTDs and mental health is. And you know, I don't have to go any further than saying the example we have is COVID. COVID is an infectious disease. You can have long COVID and so on. But the social implications, which we see now across the globe, are profound. And whilst I emphasise the estimate issue, I just can't emphasise further the fact that we have to keep beating the drum in this area.
Great, thank you, David. It's very, very enlightening. Appreciate it. I'm going to go now to Paul for a question for you. What interventions did you put in place with regards to the express priorities of the service users?
Yeah, thank you very much. Based on the priorities and looking at some of the recommendation from the theory of change process, one of the things is that the need for mental health services to be included into primary care is very essential. So in order to address that, we had a training of community health practitioners. They were trained on the WHO MH gap. That's for integration of mental health services in the communities. So in that, they were able to
they receive the training, and we try to also assist them to be able to carry out the practice in the community. And that's for the people. The other aspect is that the community health workers, some of the health workers in the communities who are not CHUs or nurses, they were also trained on psychological first aid. So that is to enable them to be able to provide mental health services in the community. So basically, that's some of the interventions that came up with regards to the express priorities of the persons affected. Thank you.
Thank you, Paul. And I will stay with you for just one follow-up question. So thinking of all of these interventions, how do you ensure the sustainability of them?
Yeah, one way in ensuring that this intervention is sustainable is to be able to push for government ownership, because these activities that we are carrying out are for a limited time. And when we are no longer able to carry this activity, we will need government to be able to sustain it. And in order to do that, we have had engagement with the government stakeholders. We've had meetings with them. We also present the data from our studies. We try to encourage them to take ownership of this project. In that way, it can be sustained.
Thank you, Paul. And I'm going to turn to you now, Zila. So first question to you is, what were some of the ethical considerations when you were engaging with the traditional faith leaders as you captured photo and audio recordings of third-party personnel?
Thank you very much. So we were cognizant that having traditional and faith healers who were generally illiterate, having them to collect pictures and audios of third-party personnel will have ethical implications. For such reasons, we ensured that we had informed consent built into the mobile gadgets that we're using. Also, we had local supervisors who were in the fields working along with these people, providing real-time supervision and assistance to them while they work. In addition, we conducted photo screening, meaning that we will evaluate pictures and see which ones were likely to be invading privacies of people. And those ones, while working with the traditional faith leaders, were able to eliminate those ones from the list of pictures. Particularly important was that recruitment were done locally. So faith and traditional healers using the snowball method were very helpful in identifying other faith and traditional healers. By doing local recruitment and having supervisors to become, supervisors to be local personnel as well, were very helpful in resolving issues of ethical implications while the studies was ongoing. Thank you.
And Zila, other than the traditional faith healers, what other ways were you engaging community stakeholders?
In addition to the photo voice studies and working with traditional faith healers, we have established community advisory boards in the counties in which we work. These boards are made up of a wide variety of community stakeholders, including persons affected by NTDs, persons affected by mental health conditions. We have female organizations represented. We have local NGOs. We have gender-based organizations as well as members of these local community advisory boards. And these boards have sufficient autonomy. They have their own elected leaders, and through ongoing engagements, they are reaching out to other persons and ensuring that the voices of community people are heard, and that community inclusion and engagement is paramount throughout our project.
Thank you, Zila, and thank you, Paul and David. Your presentations were great, and they added to the rest of the presentation today that just really showed the cross-cutting content that was in this rapid fire session. So thank you so much to you three. I'll just open this up to all of the presenters now. We're getting to the last 2 minutes of the session. And I just want to thank all of the presenters for all of their very engaging presentations, as well as the participants who have posed some great questions that made us think a bit more about all of the different topic areas. And there is exciting work ahead and lots of challenges to overcome, but I know that in these forums and the collaboration that can come out of it is very exciting, and I know that we can address some of those challenges. So I also want to take a moment to thank MYT for all of their assistance with this session and the entire NNN. I know it's not an easy feat dealing with all of these breakout rooms, but it's been seamless today. I hope that the presenters and the participants thought the same way in this session. I believe we've covered all the questions. If not, we'll try to circle back with the presenters and see if we can get an answer to those remaining questions. But with that, I will give it back to MYT for any final comments or assistance as needed. Thank you.
Thank you, Kim. Thank you for joining us for this session, and we would like to extend our thanks to all of our conference sponsors. So we will be closing the room very shortly, so please hop across to AirMeet if you wanted to carry on chatting to each other. Thank you so much and enjoy the rest of the NNN.